going to discuss about some very interesting journal articles which are relevant not only from the current scenario but also from a futuristic. Looking into these journals and these other areas is basically to look at how they can change our clinical practice. So whenever we are looking at a paper, we have to decide about whether this paper demands a change in our clinical practice or not. So I'll request all the speakers to discuss about the applicability of that to our as well as other similar resource scenarios, whether this paper will make a change in our perspective or not. So first of all, we have to decide whether this paper is really valid or not. So what are the difference between validity and reliability, Dr. Alapan?
Uh, Reliability is how much we can rely on the based on the data that is present in the paper, and validity is how much the clinical implication in that paper could change in certain clinical.
What is the difference between precision and accuracy? So which means if you rely, it may or may not be valid, but still you can rely on the paper.
No, sir, the other way around. It is valid. We can rely on that.
Yes.
But the reliability depends on the whether the paper is valid or not.
So what is the reliability then? Reliability is basically repeatability. If you do the same measurement 10 times, 9 times you get the same answer, it may be a wrong answer. That will be repeatability, reliability, or precision. So when you say validity, it is the truth that you're looking at the truth. So accuracy and validity will basically mean that you're looking at the truth. Reliability just means that this person comes 1 hour late every time he comes, he is very reliable, but he is not valid. So validity is more important than just reliability. Every time you are saying this is a horse, when you are actually seeing an elephant, you are reliable, but you are not valid from that perspective. So whether a journal is valid or not. The second major thing to look
at, reproducibility is same as the reliability.
Repeatability, reproducibility, all that are, these are the same terms as precision. These are all factors of reliability. Generalizability is very important, whether some research which has been there is applicable to everybody. So if somebody does a particular research in some particular ethnic group of different age group, it may not be relevant to our children or children across the globe. So this generalizability also becomes important. Of course, whether it provides us with some novel information from that perspective, and finally, whether that information is going to make a big change in our clinical practice right now. So we are not focusing too much about a lot of pathophysiological changes which may not have implications now. They may have implications later once those drugs are developed for that or some new tests are developed. We are focusing on clinical practice changing scenarios as to how you will help out. So whether you want to do an extra blood glucose in that perspective, what criteria you want to use in terms of diagnosing mini puberty or around that age group, or when should you think of a permanent hypothyroidism in that regard. So these questions can change our practice from that regards. All of you can go and have a look at our website learning.growsociety.in, which has got a lot of resources related to pediatric endocrinology. We offer courses including fellowship and diploma programs. We have got multiple sessions which occur including the PG lecture series, the journal club and grand rounds. Our publications are there, and you can look at our mobile application which provides realistic point of care guidance for pediatric endocrine disorders. So today we have got 3 major articles. The one is 1 hour value of glucose in OGTT, because we know that OGTT is something which is quite confusing and often the results are not reliable. So they are in fact not even reliable. So every time you do OGTT after a month, your results may be different. Forget about validity, reliability itself is a question. Then we'll talk a bit about mini puberty and the role of imaging, because a lot of patients that come to us at between 6 months to 12 months of age, how do we interpret their gonadotropin levels? How do you interpret their uterine sizes? And then we'll have a talk about congenital hypothyroidism and gland in situ, which is a common scenario. We get an ultrasound showing a gland. What is the likelihood that this patient will require for long, whether we will be able to revert it back or not? And then I'll talk about 4 or 5 new things, particularly technology related, which are really going to change out in that perspective. So we have got new ways in which there are AI models which can guide the management of thyrotoxicosis without even going to the physician. There are tools which can detect acromegaly just by change in voice, which is there. There's a novel PTH, a long-acting PTH, which is now going to be available, and salivary cortisol is going to emerge as a role for adrenal insufficiency. So there are a lot of things in store. We'll start off with Dr. Alappan, who will be talking about an interesting idea which aligns with his study, which is the role of 1 hour oral glucose tolerance test in children. Dr. Alappan. Thing which we often find difficulty in somebody who has an issue in cortisol binding. We always talk about that if you have a CBG binding issue in Cushing's, then you can use urinary free cortisol or salivary cortisol. What about adrenal insufficiency? So some lady, as we were discussing that day, somebody is already on estrogen. How do you assess that? Somebody who is having liver disease, how do you diagnose that? So this study really looked at whether salivary cortisol has a good marker as far as adrenal insufficiency is concerned. We all know that salivary cortisol has been used for diagnosis of excess, but what about deficiency? So when you look at this graph, you're seeing salivary cortisol on the y-axis and serum cortisol on the x-axis. There seems to be a linear relationship. And after a particular level, once your cortisol level goes above 500, the relation is much more steeper. Before that, the relationship is not very good. What does it mean, Alappan? Is it better for excess or is it better for deficiency? The graph is much steeper beyond 500 nanomoles per liter. So it will give you a better picture for excess, but for deficiency also it is linear. The other important thing to remember is that on the right hand side with those triangles, they are talking about females who are on estrogen. So there this serum cortisol is going bizarre. You're seeing much higher levels of serum cortisol while the salivary cortisol is not going up. So what this means is that somebody who is on estrogen, or if somebody has CBG excess or deficiency, salivary cortisol will be good correlate, not the serum cortisol. And this is something which they wanted to do. So when they did a synactin stimulated salivary cortisol, and they found that it was a reasonable tool with 87% sensitivity and 85% specificity. So this is a tool which can be considered in somebody who has a problem in terms of cortisol binding. So we can now think of salivary cortisol also not only for cortisol excess, but also for cortisol deficiency in that perspective. The second study is about interesting, it's not more of a phase 1 trial, but just as an update that we know that parathyroid hormone is being used for treatment of hypoparathyroidism. The problem there was that it's a daily injection, and daily injection causes a lot of fluctuations. Levels can go up and down. So now we have a once weekly PTH, which has already been developed. And this is basically a replacement therapy, mainly acting via the fatty acid binding, something like detimir, which was acting via the fatty acid binding, and those things were there, and then peptide was gradually released. So once weekly PTH also has come up, and its pharmacokinetic pharmacodynamic profile is also similar to daily PTH. So again, probably we are from growth hormone to GLP-1 analogs, we are now looking into parathyroid also once a week preparation, which is there. A very interesting study which could be relevant from a clinical perspective is what really is a normal CGM analysis. We all talk about time in range, 70 to 180, we talk about 70% and other parameters, but what do normal people have in terms of glycemic index? And this is the variability in which they did a study in around over 1,000 children, 1,000 individual, not really children. 560 were normal, 463 were pre-diabetic, and 152 were diabetic. And we can see clearly that there is a variation in terms of the profile. So what they defined is that somebody who has normoglycemia, they're spending less than 1% of their day in levels more than 180. So you can have occasional readings going above 180, but it's only 1%. And around 3 hours a day in between more than 140. So this is the normal variation. So time in range, if you look at 70 to 180, will be 99% in the case of a normal individual. So you can't use 180 as a cutoff. You can use maybe a lower cutoff. For pre-diabetes, this figure becomes 3 times. So they are spending 3% of their time above 180, while they are spending nearly double their time above 140 compared to a normal individual. Then the curve really steeply increases when you talk about diabetes. Of course, you're talking about a huge increase of 13 times increase in more than 180. So this is a good way to look at. So this 6.3 hours, which basically mean what? Somewhere around 30%. So 25 to 30% time in above range, which is normal. So I think this is very helpful. What are your perceptions on this? If you use 180 as a cutoff, how much time do you think? 99% in your study, patients are within the range, 99%?
Yes, sir. Mm.
And so this is pretty much, I think, similar to our experience as well, that when we are looking at CGM, and this is something which you can look at. What about those who had pre-diabetes? What about those who had diabetes? How much was the correlation which was there? So this is something which is there. So how many of them have time above range, do you think?
In my study, uh, there are few cases where they are just 1% or 2%.
So not more than 20%. And most of them will have abnormalities in other parameters as well.
Yes, sir. Mm.
So this is something to remember, that now this could be a tool to look at what really normoglycemia is. And when we look into the mean value, we can see, of course, normoglycemia are going much on the left side and diabetes is going on the right side. Their mean value is 130. Normal individual mean value is 106. So if you want to use a single mean parameter, 106 is the average, 114 is the median value of glucose in a normal individual. While for diabetes, it becomes 151. And when we look at the peak value, it goes to 199, 212, and 274. So, of course, there's a big variation there. So, these are the figures we can think of in terms of using. It's a good study to follow up from that perspective. Now, this is another very interesting study in which they looked at ways in which they can cut down on physician visits based upon clinical parameters. And this is a AI-based model which is looking at how do we change the doses of carbimazole without visiting the doctor. So they've developed a lot of AI things and they looked at so many parameters. If you look at, they will be much, they like the TSH dose, how much the TSH has changed, how much the T4 has changed. So based upon that. So if you go by a decision tree, so what is the difference between a decision tree and an AI decision?
Decision, sir.
So we have got a decision tree based decision and we have an AI based decision. So what is the difference there?
So clinical decision taken is
So decision tree is basically if your FT4 is more than this, TSH is less than this, you decrease by 10%, something like that. But if you look at AI, it is looking at multiple parameters, which it has already decided by itself, not you have told them. While decision tree, you will tell, okay, if you have this, you do this. Here, they have looked into so many parameters and then they decide that, okay, this case, maybe should not increase the dose, maybe we increase the dose. And what they found was that it is very good and it may reduce the number of visits per se. So I think when we talk about AI, often this is for the dose for carbimazole, this could happen for short stature evaluation, this could happen for dose of insulin. So I think we should count our days as to how long we will be surviving, because then AI will be doing anything. So this is a good study which has been published. And what they really found out whether the errors in the follow-up patients were more as compared to new ones. But I think with time they can evolve the technology. So now AI is going to make decision about things, and this could be something which we have to find it challenging in that perspective. This again is a very interesting study, was a voice analysis as biomarker of acromegaly. So if you want to screen somebody with acromegaly, they thought that if you look at their voice, it is different. And when they looked at these data, they found that compared to control, the scoring of acromegaly patients were different. So what they did was they developed a AI model which can then tell you that, okay, just by the voice, whether you can diagnose acromegaly or not. So now we are looking at something which has got a huge data sets. So when you say CT, you're looking just as a radiologist will be looking at few things in CT, but AI will take a look at everything in CT and then it will try to decide, okay, does this correlate with encephalopathy? Does it correlate with something else? So by voice, they are going to detect with acromegaly, and I'm sure a lot of things will happen. So maybe by picture of a child, they will tell you that obviously there are tools which tell you about phase two, all those things, but I think many more details will come up from that perspective. So this is something which we need to be aware about. So we try to cover all those interesting topics. So all of you can go and have a look at our website, our courses, our public.